Hi everyone, I'm Hartford Healthcare's Tina Verona. Thank you so much for watching. Today I am happy to be joined by Dr. Craig Allen. He's the medical director at Rushford, a provider of addiction and mental health treatment programs. Today we're talking about addiction, specifically alcohol addiction. We know this is a serious and sensitive topic, but we do encourage you to send in your questions anonymously and we'll ask them for you to connecttohealthier@current.com. Dr. Allen, thank you so much for being here.
Thank you for having me.
Such an important topic. Let's start out. The National Institute of Health has released guidelines. Let's first sort of set the stage with those guidelines in terms of men and women and how much drinking per week constitutes under those guidelines.
Sure. So I'll start by saying the safest way to approach alcohol, despite some of the claims that we've heard about in recent years about health benefits, the safest way to approach alcohol is not to drink it at all. Mm-hmm. These guidelines that have come out of the NIH, and they've been around for a little while, were designed to realistically look at the fact that most people do drink. At some point during the year, well over half the population, closer to 75%, drink alcohol.
Just depends on how much you're drinking.
Well, so that's right. That's where the guidelines come in. So how much, if it's so unsafe, but really it's part of our culture. It's very common. It's associated with weddings. It's associated with celebration. It's associated with football. So how much is safe, or what would be safer in drinking? And that's where these guidelines come from. So for men, in a week's span, drinking no more than 14 drinks is felt to be safe, relatively safe. And on any given day, no more than 4 drinks. For women, it's different. Women have different physiology and they handle alcohol a little bit differently, and they're more vulnerable to the negative effects of alcohol. For women, 7 drinks a week or less, and no more than 3 drinks on a given day during that week. So these guidelines were designed looking at what's relatively safe, as I said. So 1 in 100 people following these guidelines might still develop an alcohol use disorder. But on the other hand, 99 out of 100 following these guidelines will not develop an alcohol use disorder.
And I think it's interesting to point out, too, is that women, middle-aged women, you're seeing an increase in terms of women having an alcohol abuse problem.
Mm-hmm. Mm-hmm. I think that's really important. There was a study done looking at mortality data from 2007 to 2017. And it showed that there was over a 30% increase in the number of people dying from alcohol-related disorders. However, with women, it was 85%.
Now, that's surprising. Are you surprised by that number, women versus men, and have it being so high? And what do we attribute that to?
Well, I'm concerned by that. But what we do know is that all the negative aspects of alcohol impact women more so than men, or quicker, faster. So drinking the same amount, a man and a woman will become addicted quicker. Mm-hmm. A woman will suffer the negative consequences like memory loss and the associated physical problems like gastrointestinal problems, cardiac heart problems, and also cancer. There are 6 different types of cancer that are associated with alcohol use, including breast cancer.
Yeah, and I think that's something that you may not realize. I think a lot of people don't realize that alcohol can lead to different types of cancers, particularly breast cancer among women.
That's right. That's right. And not to mention, I think something that people might be a little more familiar with is the association of alcohol use and mental health problems. Mm-hmm. So an association with depression, with anxiety, and it goes both ways.
Right.
People that have an anxiety disorder or suffer from depression are at a greater risk of developing an alcohol use disorder, obviously, if they're drinking.
Right.
And people who are drinking have a greater risk of developing an anxiety or a depressive disorder. In fact, and this is something that isn't well publicized, but the association between alcohol use and suicide is greater than having a major depressive episode or bipolar disorder and suicide.
Do we know the connection there in terms of why that's so much greater?
Well, yeah, alcohol is disinhibiting. So alcohol sort of takes away your brakes. Alcohol can lead to impulsivity, so making decisions without considering them. Alcohol can lead to increased rates of aggression. Alcohol can lead to cognitive impairment, so your judgment isn't so good, your thinking through a problem isn't so good. Those are all reasons that it can be associated with suicide. If someone has access to a gun, for instance, and they're disinhibited, impulsive, angry, or sad, then they're more likely to do something. But also, there's an association with people who drink becoming more depressed and feeling dysphoric. You feel really great when you're having that drink, but I think a lot of people can relate to the feeling the next day where you're dysphoric, not so happy, maybe feeling guilty, maybe feeling bad.
And then that leads to even more alcohol consumption because you want to get to that euphoric state again.
It can. It can, and that's the cycle that people can get into and really can get them into trouble.
Yeah, absolutely. We are receiving a number of anonymous questions through connecttohealthier@current.com. We have one, Dr. Allen, is alcohol rehab expensive? What steps should I do to prepare for the detox process?
So it depends on your insurance. It depends on where you go. There are some programs that don't accept insurance, or they will accept insurance, but they're not what's called in-network, so the cost is really much higher than if you were using your insurance. So you have to explore that. I'd recommend you call your insurance company. If you don't have any insurance, it can be expensive to go to a program where you're actually living there and getting your treatment while you're there. But there are outpatient programs that are less expensive, and you don't have to go to a rehab. You don't have to go to a place where you live to get treatment for alcohol use disorder.
Right, and of course I think the important thing is to be evaluated to find out and to determine what the best course of treatment is, whether it's outpatient, inpatient, rehab, whatever.
Right. You know, the question being, how do I prepare for it? It's important to, how do you know when you have a problem? I mean, sometimes people start to notice when they stop drinking, they don't feel good. Some people, when they stop drinking, not only do they not feel good mentally, not feel good physically, but they actually can have significant physical symptoms, high blood pressure, and that can be very dangerous, and it can lead to confusion. Some people even have psychotic symptoms, and it's really, really important to talk to a medical provider if you have any of these kinds of significant withdrawal symptoms.
And the question about family, what can family do? That family support is so big, but you know what? How do you, if you think that your loved one is experiencing an alcohol problem, how do you even broach that topic with that person?
Right, and that there's an organization, a support organization. There's AA, there's Smart Recovery, but there are also programs for families that are available. And there are a number of really good websites that offer advice to families. How do you approach a loved one who is using alcohol and doesn't want to stop? How do you work with a loved one who is trying to get help? How do you work with a loved one who's gone through a program? And how can you continue to help?
And in order to get somebody to get help, is it true in your opinion that they have to admit first that they have a drinking problem in order to get help? Or if they don't admit it, can they still get help? And how do you help them?
Yeah, one of the strategies that some primary care doctors are trained in and some therapists are trained in is called motivational enhancement or motivational interviewing. And the goal there is to let the person who has the problem go through what are their goals, what's going well for them, what's not going well for them. And they come up themselves with this sort of uncomfortable space where they say, I'd like to get that new job, but I just don't have the energy to look things up online and spend the time I need. And he said, gee, well, why is that? Well, on the weekends when I would have the time, I go out with my friends And the next day, I was kind of sleeping it off. You say, gee, is there any other approach that might help? So one strategy is to try and identify the person's own concerns about how they're functioning with alcohol, and let them come to the conclusion that maybe they'd like to cut down, or maybe they actually want to stop. How can a family do that? It's having that courageous conversation.
Absolutely. Dr. Allen, we have a question from Samantha on Facebook. She asks, I drink a glass of wine a few times a week and often more on the weekends. I don't believe I am dependent on it. However, how would I know if this is a problem or starting to become a problem? Does that go back to those guidelines again?
Well, you can, number one, you can look at the guidelines, and if you're exceeding those guidelines, those are your risks.
Yeah.
If you're staying within the guidelines, then your risks are much less. However, even if staying within the guidelines, if drinking alcohol is affecting your relationships, if it's affecting your responsibilities at work or your responsibilities at home, if it's affecting your health, either your physical health or your psychological health, then that sounds like it could be a problem for you, and you might want to cut back. You might want to explore strategies to decrease your use. There's an interesting phenomenon going on, and I've heard about it since the beginning of the year, and it's Dry January.
You're right.
And it's an effort. It comes through social media where people commit themselves to not drinking for the month of January. And people who've done this in the past say, you are going to be surprised at how much energy you have, how much clarity you have in your thinking, how much your mood improves. And so, one of the things that I say to people when they say, gee, I don't know if I have a problem or not, and they've come to see me because they're depressed or they're anxious, and we start talking about substances and alcohol, I say, I don't know if it's the alcohol that's making you depressed or anxious, and we'll talk about therapy for the depression. We'll talk about some medications for the depression. But here's one other thing you can do. Let's have you stop drinking. This is for someone who's not physically dependent and isn't going to have withdrawal symptoms, or not
Maybe
severe
who's
withdrawal
drinking
symptoms.
socially.
Who's drinking socially? We don't really know.
Right.
And I'll say the same thing to someone who might be smoking marijuana or using some other type of drug. I'll say, let's stop that. And when that person comes back and says, I'm really struggling with stopping, then we might focus a little bit more on the substance.
That could be the onset of a problem.
Yeah, that could be the onset. It could be a problem that has brought on these other, a co-occurring problem.
Right.
What we have found out through the years is that, and through a number of different studies, is that you, as the treater, need to address both of the problems if someone comes to you with a psychiatric issue like depression and a substance use problem. Your depression does not get better if you don't address the alcohol, if in fact it is negatively impacting that condition.
If someone comes to you as a social drinker and says, hey, I just have a couple here, a couple there on the weekends, but do you look at their genetic history too? Because, and that, could that person become an alcoholic or somebody who abuses alcohol because of that genetic predisposition?
Well, yeah. One of the things that I would say is, you look at the guidelines, and so, okay, you're within the guidelines, and that makes it safe. But 1 out of 100, there's millions and millions of people that live here in the United States, so that's a lot of people that still can develop the disorder. Right. So who are those people, and why are they at such great risk? And the risks include, I mentioned being female increases your risks, but also starting to drink before your brain is fully formed. So before the age of 21 significantly increases your risk. Having a family history, as you mentioned, a little bit over 50% is thought to be genetic in terms of people who develop an alcohol use disorder. So if you have a family history of it, then that puts you at greater risk. And I mentioned earlier, I think that psychiatric disorders can put you at greater risk of developing an alcohol use disorder. So as a social drinker, if it's not impacting your functioning, if you're not concerned about it and people around you are not concerned about your drinking, then there's no reason that you would have to stop drinking.
To go any further.
But it's always
Right.
it's always your choice. And
Right.
if you have a difficult time actually stopping, then that's where you're going to maybe need some help.
Maybe need some help. We have another question from an anonymous viewer. You mentioned men should have no more than 4 drinks a day and 3 for women. What percentage of alcohol is acceptable to have in each of those drinks?
Yes. So what is a standard drink? And there's a slide presentation that I gave a few weeks ago, and I had this picture of, it's a cartoon, and it's these 2 guys having lunch, and they say, gee, I only have 1 at lunch. I wonder why it affects me so much. And they're sitting in front of these ginormous glasses of beer. So what is a standard drink? There's differences between wine. It has more alcohol than beer. So 5 ounces of wine is considered to be equal to a 12-ounce glass or can of beer. But beer has different alcohol content too. And standard beer is probably around 4.5 to 5% alcohol. But some of these craft brews that are out there and these IPAs can have up to double that amount of alcohol.
Wow.
So when you go out for a drink, it's important to know how much is in there. So 1.5 ounces of hard liquor is considered equal to 5 ounces of wine is considered equal to a 12-ounce beer.
Yeah.
If you're drinking a fortified alcohol product or one of these higher potency beers, you should calculate that when you're deciding, how many you should have or should you have another, which does bring up the point. What are some of the things that you might want to do to try and cut down? And one good strategy is decide how much you're planning to drink over the course of the week, over the course of that night, before you even start.
Right. So when you're actually taking those drinks, and some drinks taste better than others. For women, it's like, we like the fruity drinks, and those can go down pretty easily.
Yes.
And before you know it, you're drinking 5 or 6, and you don't even realize it. What actually happens to the brain when alcohol consumption enters into the body? What's going on up in the brain?
So when you drink alcohol, there's a release of neurotransmitters in the brain. And the neurotransmitters include dopamine, norepinephrine, serotonin. These are neurotransmitters that are associated with pleasure, relaxation, and energy. Like norepinephrine is something that is released when you get a big jolt of energy. And that's what's happening when you're drinking the alcohol. But something different happens after you're done drinking and your alcohol levels start to fall. And that's more on the sleepy side, sedated side. And, in some cases can be, especially people who are drinking more, and maybe the next day can be negative affect.
When that kind of
irritability.
comes down, is that when impairment begins to set in? When does impairment happen?
Well, the impairment can happen either way.
Yeah.
When your blood alcohol is going up or when your blood alcohol is going down. The impairment happens because alcohol has a lot of different effects. Not only does it affect every organ in your body, but it affects many different parts of the brain. It affects your cerebellum, and your cerebellum's in the back of your brain, and that's how you coordinate your movements. It affects the prefrontal cortex, which is right over your eyebrows there. And the prefrontal cortex is what allows you to make decisions, judgment, put on the brakes in certain situations, decide, am I going to have another or not? What do I have to do tomorrow? Am I driving? And if that part of the brain's working well, you make decisions based on past history and things that you know in education. But when you drink alcohol and use a lot of other addictive substances, that part of the brain slows down. And there are studies that are done looking at the parts of the brain that are active. They use radio-labeled glucose. And the parts of the brain that are active, they use more of this glucose. And they show that the prefrontal cortex making these decisions is less active. It shows that the cerebellum, coordinating your muscle movements, is less active. It shows that the temporal regions, which has to do with memory, is less active. And that kind of makes sense when you think about how alcohol affects people.
Absolutely. To someone who has abused alcohol for many years,
Mm-hmm.
does that in any way permanently damage any part of the brain at all?
It certainly can.
Yeah.
There are a number of different disorders. It can lead to premature dementia. It can lead to different types of memory problems. We mentioned earlier the impact on the developing brain, so in younger folks, and that can affect their learning, their attention, their ability to concentrate. But also there are more serious disorders that are associated with drinking alcohol for long periods of time that can affect your psychiatric functioning and even lead to psychosis. There's Wernicke's encephalopathy is the medical name for one of the disorders that's caused by heavy drinking for long periods of time, which causes thiamine deficiency. Thiamine is vitamin B1. And so when someone's a heavy drinker, there are certain types of vitamins that, like the hospital, the emergency room will try to get into their system.
Right, to combat the whole host of problems that it causes.
Right.
In case you are just joining us, we're talking to Dr. Craig Allen. He's the medical director at Rushford. And we thank you so much for joining us and asking these great questions. Dr. Allen, we have another question from Laura. She asks, what type of alcohol rehab will be the most effective? Thanks, Laura, for that question.
An alcohol rehab that is going to take into account the whole person. And so a program that looks at what are the medical issues going on, what are the psychological or psychiatric issues going on, what is the social situation that the person is in, and what is the financial situation that the person is in. All of those things, if you look at social as relationships and work and family and kids, all of those things can significantly impact a person's functioning and the likelihood that they're going to endure stress. And stress is highly associated with going back to drinking.
Yeah. I want to talk about Rushford for a little bit. There are a lot of programs at Rushford. You are changing lives, but I think more importantly, saving lives. And I think some of the statistics here in Connecticut are about 6,600 families are impacted by some type of alcohol-based treatment a year at Rushford, which is such a significant number, and it goes to show the depth and breadth of the problem that we have. And there are many things, there are many facets that you do to help treat, and one of that is these recovery coaches that are in the emergency department, which is so critical, I think. And I think even the numbers for that, I think in 2017 I read 90% followed through with getting treatment as opposed to 20% when we didn't have recovery coaches. So first explain what a recovery coach is and how vital is that to have that right in the emergency department, because that obviously is a gateway to somebody coming in.
It was a number of years ago, the first time that in our adolescent program, which is over in Durham, this was many years ago now, we changed what we were doing in that program. I thought we had a very good program. The clinicians met with the families and they met with the kids. I met with the families, I met with the kids, but we weren't getting through to all the kids.
Right.
There were a lot of kids we weren't getting through to.
Or they weren't following up probably either.
Or they wouldn't follow up when they left, and they
Right.
just kind of didn't get it.
Yeah.
And we changed things a little bit, and we brought in people with lived experience.
Yeah.
So sometimes people call them peers. We're in the Hartford healthcare system now, we refer to them as recovery coaches, and they had that certain something that could connect with these kids.
That missing link.
That missing link, that magical piece that as a physician, as a clinician, as a parent, it wasn't there.
Right.
Was it because they'd gone through the same type of things in the past? I think that's something to do with it.
Yeah.
But the light bulb went on. And we use recovery coaches at Hartford Healthcare in all of our emergency departments for anyone with a substance use disorder. We try to get them to talk to the recovery coach. And as you mentioned, over 90% of the people that did talk to the recovery coaches ended up in some type of treatment or in a recovery-based mutual support organization like AA or NA or Smart Recovery. So that was wonderful. What we decided to do was we we know that people who are in a treatment program, so we have medication-assisted treatment close to home, our match clinics, and we've got 12 of those across Connecticut through the Hartford healthcare system. And we know that people with substance use disorders and alcohol use disorder do better. We know less about what type of residential program is going to work for them.
Right.
We know less about which type of therapy is going to work. We have some medications that are helpful. We have therapies that are evidence-based. But the thing that is most telling is the people that do the best are in treatment the longest. And the cutoff points looks to be about a year. So keeping people in treatment for a year helps them to get into recovery and stay in recovery.
Right, and ultimately have success.
And
with the
have
recovery.
the success.
Right.
So with our match clinics, we decided to bring these recovery coaches into the clinic to meet with people that are coming into the program and to be able to reach out to people if they stop coming in.
Right.
And they have the ability to go into the community, call them on the phone, text them, go out for coffee.
And that's the key there, that these match programs are strategically located in suburban type settings in the community because, it's not just an inner city problem, it's everywhere. Right. And people do better when you kind of go to them.
Yeah.
And it's more convenient.
Our match clinics have a team.
Yeah.
There's a doctor or a nurse practitioner that works with the clinician or clinicians. There's a recovery coach.
Yeah.
There's and when I say there's a recovery coach, let me be clear. We received funding from SAMHSA, which is a government agency, to do a number of things in our match clinics, one of which is to include the recovery coaches. And we also had a philanthropic gift to support this process. So we're at the very beginning of putting the recovery coaches in place. Part of what I'm talking about is the vision and the state of the system a year from now.
Right, but it does work. That 90% to 20%
that's
ratio
in place.
is
happening now.
Is huge.
Yeah,
that's significant and impressive. We have a question from Steve. He asks, how much alcohol is too much? Depends on how long you want to live and what quality of life you want. How many cigarettes are too many? I personally believe alcohol is far more dangerous than tobacco. Steve, thanks for that. What's your take on that?
Which one's more dangerous? Well, I mean, I don't like that debate. They both have pretty significant risks. If you want to look at the number of people who die every year, far and away, tobacco kills more people in the United States and across the world, far and away. But alcohol is the third leading cause of preventable death in the United States, the third leading cause. So how much is too much? Well, you probably shouldn't smoke any cigarettes at all. And with alcohol, we have the guidelines from the NIH.
Right. So we have a question from Casey. Does alcoholism affect people differently based on age?
It does.
And we talked about women, middle-aged women.
We talked about women. We talked about the younger population that's more vulnerable to developing these problems, and maybe some of the changes in the brains that happen in a developing person, maybe they will be sustained and continue to be a problem the rest of their lives.
Yeah.
With the older population, there's really less reserve. As we get older, we might not lose a lot of our brain power, but what we do lose is our reserve and our ability to tolerate and bounce back from a disease or an illness.
It's not so easy the older you get. Dovetailing off of that age question, weight, I'm sure, plays a factor in terms of alcohol consumption, right?
Right. Sure. I mean, weight does too. With age, not unlike with women, people who are over the age of 65 are at a greater risk of developing an alcohol use disorder, even if they're drinking, at a greater risk than someone who is younger who is drinking.
Right.
And so those guidelines that I mentioned before, over the age of 65, the same guidelines as for women.
Right.
So no more than 3 drinks in a day, no more than 7 drinks in a week. So the geriatric piece. You mentioned weight, and weight can significantly affect how someone is able to manage their alcohol. But it's not a cut and dry kind of thing.
Right, right.
there are legendary stories about a professional wrestler, Andre the Giant, who weighed close to 600 pounds and was an alcoholic. That was not written that he was an alcoholic, but it's pretty clear he was an alcoholic when you read the stories. But he could drink enormous amounts. It probably has less to do with your weight than how often and how much your body has been exposed to alcohol. And there are people that can come into the emergency room who have drank enormous amounts and talk to you as though they are sober.
Right.
That doesn't mean that alcohol is not negatively affecting their system and putting them at risk for cardiac problems and putting them at risk for different types of cancers and impairing, their cutting short their potential in the future. But they can drink more alcohol.
You mentioned the older you get and the more prone when you're drinking, it's more difficult to bounce back. But the younger you are when you start drinking, the more it can have a developmental effect on your brain. Is that right? So there's an interesting juxtaposition that you can't bounce back when you're older, but when you're younger, you're not going to, you're going to lose some of that developmental
There's another
activity.
interesting, unfortunate in a way, thing that happens with younger drinkers, so people under the age of 21 or so, and probably people a little older than 21, is that their metabolism is faster. And the impact on coordination and speech is maybe a little bit less, and the impact on memory might be a little bit more. So a younger person who drinks can drink a lot, can not present as stumbling around or slurring their words, and then might forget the next day. So sometimes I describe that as the imperfect storm. So younger people, some of them tend to drink because it makes them less uncomfortable in social situations. All adolescents think that everybody in the world is focused on them and what they're thinking and what they're going to say next, which isn't true, by the way. But when they drink the alcohol, they feel more comfortable in the social situation. And unfortunately, they're not like someone who's middle-aged and may go to a party and have a couple of drinks and end up being that Billy Joel song, which is about drinking too much and being the life of the party, but embarrassing everybody around and themselves.
You never want to be that person.
Right, you don't want to be the person. I'm not saying that younger people can't do that too. Of course they can, but it doesn't happen as quickly as with older people.
Right, interesting. So we have a question from Rebecca. Can past trauma or abuse impact alcohol use or abuse? And if so, is the treatment plan different for a person like that? Thanks for that question.
That's a great question. Trauma is a significant risk factor for developing any type of substance use disorder, including alcohol use disorder. And if you are treating somebody who has an alcohol use disorder and has a trauma history, you have to provide treatment for the trauma component, or that person is going to continue to be at very, very high risk of continuing to drink because the symptoms from the past trauma are going to continue to rear up.
I mean, any significant, I think, probably life-changing event, even maybe a divorce or something that really negatively impacts a person can lead to that, would you say?
Yeah, absolutely. Absolutely. And I was reading an article, actually, it's a patient handout from the NIH. So it's available online, which was suggesting different strategies to try to cut down your drinking. And one of the strategies was to, one that I'd mentioned was to identify how much you plan to drink, keep track of how much you're drinking, space your drinks. By space your drinks, you're supposed to have one an hour. Switch up with water, and you mentioned a fruity drink, have one without any alcohol, that type of thing. But to also anticipate these situations, these stressful situations that might lead you to drink, and ahead of time try to come up with other strategies to try and manage your stress. If you've found that drinking hasn't really helped, or even though it may help in the moment, the next day is not worth it, then it actually works to have a strategy in place first, because alcohol is something that has been around since the beginning of human time. And there may be a special part in our brain that is designed to respond very, very positively to alcohol. So there's different tricks your brain may play on you to allow you to continue to do something that has actually led to a very negative experience the next day.
Right.
And people tend to forget about that, or they fool themselves.
Right. I do want to mention opioids. You know, they're getting a lot of attention in the news. There is an epidemic that we've seen nationally. The numbers keep rising. But you know what? Alcoholism is a big issue too. That's right up there in terms of actually being an epidemic. I mean, the numbers continue to rise with alcohol.
Yes.
Talk about the difference in treatment. Is it treated with medication, alcohol versus opiates? Talk about the difference in treatments.
Yeah. So both for an opioid use disorder and for an alcohol use disorder, there are different strategies that work. So there's therapeutic strategies, which often are cognitive behavioral strategies, and that is looking at your thoughts, your feelings, and your behaviors, and trying to map how one affects the other and then trying to make the changes that will lead you away from engaging in that activity. And there are a couple different other types of therapy that can be very helpful. There's also FDA-approved medications for both of the disorders, but the medications work differently. For opioid use disorder, the medications can either be medications that are opioid replacement medications, like methadone, where you go to a methadone clinic, or a buprenorphine-based medication, like the name brand Suboxone, where you can get at your doctor's office if that's something that they are comfortable doing and they've gotten their special waiver. And that replaces the opioid, stops you from going into withdrawal, stops the cravings, and makes you feel comfortable so you can engage in the therapy that I talked about. Right. And then there's another medication for opioid use disorder, which is called naltrexone, and there's a form that is extended release, that's an injection, and that works differently. That's not a replacement medication. That actually blocks the receptor. So that's how the medications work for opioid use disorder. For alcohol use disorder, it's a little different. Although naltrexone is available for alcohol use disorder too, it doesn't block the effects of alcohol, but it does something a little different and a little less well understood, in that it dampens down the positive reinforcement from drinking and can also decrease the cravings and the urges to drink. So naltrexone is available for alcohol. Another medication called acamprosate, that's the generic name. Campril is the name brand. That medication is available. And that medication can, once you've stopped drinking, stop the urges and the cravings. And then there's a medication called disulfiram, name brand is Antabuse. And if you drink on that medication, it makes you sick. So it's a deterrent.
Got it.
A
To
negative,
drinking. Yeah, it's the opposite effect.
Right. So similar to the two, there's therapy that's available and can be quite similar. Cognitive behavioral therapy. It can be done in groups or individually. And there's medications that are available. There are a couple of other medications for alcohol use disorder, but they're not FDA approved. But they are recommended by...
experimental even?
They're not really experimental. Actually, there's plenty of evidence, and they would be FDA approved if they were, if the drug company felt there was an advantage to pursuing that process. But the studies support their use. That's topiramate and gabapentin, they're called.
Are these lifelong medications?
No. For an opioid use disorder, it's less clear. For an alcohol use disorder, much less frequently someone would continue on them for a long period of time, although there may be people that would take them for a longer period of time. Both of the disorders, too, should have a recovery component to it. We talked about recovery coaches, we talked about AA,
That
NA.
goes hand in hand. I mean,
it does.
You really have to have both.
It does. And as much as the family can get involved, can be involved, that's really
That family
important.
support is so critical. We have a question from Ashley. She asks, how does insurance affect access to treatment? For example, do people receiving Husky or Medicaid have easy access to care in Connecticut? Thanks, Ashley, for that question.
Medicaid, Husky, there are programs available. I mean, we're talking about alcohol use disorder?
I would think that would be her question, yeah.
So, there are a number of programs available. You know, Rushford accepts those insurances at all of our programs. For an opioid use disorder, it's a little more challenging in that to find a group or a program that prescribes these opioid replacement medications or that long-acting naltrexone form, that injection form, that could be a little more challenging, but it's getting easier now. All of the community behavioral health centers now in the state of Connecticut, the state-run programs provide medication-assisted treatment. So that, and they all take Medicaid. They all take Husky.
Yeah, just because of the issue of it. Lastly, Dr. Allen, to those out there watching us, if they feel like they might have a problem or maybe on the cusp of a problem, what do you want to say to those people that might be watching us?
What you should know is that you can talk with your doctor. You can, and depending on where you're at, if you think you might have a problem, then go to the NIH website. Take a look at the patient education and the patient handout, and give it a try and see if you can reduce your use. And why don't you have a dry February?
Right.
And see if that's something that you can do and that feels right for you. With the caution that there's some people who have become physically dependent, meaning they're drinking so much that their body has adapted to it. And if they stop drinking, they're going to have withdrawal symptoms that can be pretty disturbing and severe and potentially even life-threatening. So someone who's drinking enough to have these withdrawal symptoms would have high blood pressure, be flushed, be sweating, rapid heart rate, might increase the risk of a heart attack, and they could have confusion, and it could be even thought disorder, psychotic symptoms. I mean, that is a medical emergency.
Right.
So most people who say, gee, I think I might be drinking too much, can cut down without a problem. They might have very minor withdrawal symptoms. But if you're having trouble cutting down, or if you're having any more serious, or you're concerned about your withdrawal symptoms, then talk to your doctor.
Dr. Allen, always a pleasure. Thank you so much. I know that you are so passionate about this topic, and thank you for all the wonderful work that you do in helping so many people each and every day. So we thank you. And we thank you out there for joining us and for asking your questions anonymously. I know this is a serious and very sensitive topic, so we do appreciate you taking the time to write in those questions anonymously. So thank you, Dr. Allen, and thanks again for joining us. If you need help, you can call 1-855-825-4026. I'm Hartford Healthcare's Tina Verona. Thank you so much for joining us. We'll see you next time.